Invitation. I'm going to present a case. It's a relatively old case, but it's demonstrated because of the unexpected complication that we should all be aware of. This is our heart team at St. Luke's Hospital, and these are my disclosures. Now, 83 years old female, suffering with severe AS, and back in 2014, she received a Percival small valve due to the aortic stenosis. She had radiation for SCA breast in 2017. She came to us about 6 years ago with progressively worse breathlessness, and she already had 2 admissions with acute heart failure and also had moderate kidney renal chronic renal failure. The echocardiogram showed severe bioprosthetic valve stenosis with a mean gradient of 54, good LV, severe pulmonary hypertension, so a quite advanced case, and mild mitral agitation. The coronary geography showed normal coronary arteries, and this is the transthoracic before, good LV function, and severe gradient to the Percival bioprosthetic valve. She had a quite high Euroscore, and we decided to perform a TAVI on her. Because it was a small Percival, we decided to go ahead with the supraannular Evolut 23 millimeter TAVI valve. Because he was quite sick, we wanted to perform a transesophageal also and see what was happening. And you can see that there is a quite thrombotic environment. She was in a state of low flow. You can see a lot of smoke in her LA and possibly some thrombus in the LA appendage. And also you can appreciate here the motion of the leaflets of the Percival valve, which are quite akinetic. So this is the status of her LV, and this is her aortogram. And we went ahead with the routine procedure of valve-in-valve TAVI operation. By the time we were trying to cross the valve, the patient suddenly became grossly hypotensive and hemodynamic collapse and simultaneous VF arrest. So at the time, we didn't know exactly what was happening. You can see here LV. You've got to consider some options. First, tamponade. Second, whether we damaged one of the leaflets while we were trying to cross with a straight wire. And the LV showed a lot of severe hypokinesis. You can see that suddenly the LV became very hypokinetic. We performed an aortogram in order to see whether we had any annular rupture. And I don't know whether you can see that there was something strange happening in the coronaries. So we thought that coronary damage could be a cause of her sudden hypertension. We took a guide cath, and this was the first appearance. Remember that her coronaries were normal. All the left system was full of thrombus. So we assumed that at the time that trying to cross the valve, that not only the heart, but the valve also had thrombus. So some thrombus was dislodged and went directly to the left main and blocked both arteries. The patient was pretty unwell, you can understand the time. We had to do something very quickly. So we tried to aspirate. We first aspirated the circumflex, then the LAD. Fortunately enough, the circumflex opened quite quickly after 3 aspirations, but the LAD required 15 aspirations and 3 aspiration catheters that were used. And you can see all the thrombus that we extracted from the left coronary system. This is the first appearance. As soon as we opened the dominant circumflex artery, the patient started recovering a bit. The blood pressure started, she was on full inotropic support, but the blood pressure started going up a bit. We tried hard with LAD, and we managed some thrombectomy proximally. We couldn't advance the thrombectomy catheter more distally. So we took a filter XT, we performed another thrombectomy to the lady who had some flow distally. We performed a small balloon and another thrombectomy catheter. And also we gave intracoronary abiximab and gradually starting restoring the flow down to the LAD. And we performed the thrombectomy to the diagonal as well. And in the end, we managed to have a good flow down to both vessels. So all this took some time, and the patient started recovering, but she was still on inotropes. So we decided to go ahead for the TAVI and not to stop the procedure. We used a smaller catheter. We used an AR to cross uneventfully this time. We put the confida. The evolute couldn't actually cross, so we had to pre-dilate with a balloon. We changed the Landerquist again, the evolute couldn't cross, so we dilated with a balloon. And after the balloon, the evolute crossed quite easily and was deployed according to our initial plan. And this was our final angiographic picture. No stenosis, trivial regurgitation, the hemodynamics fully restored, and the transophageal showed full restoration of her LV function and very good functioning of the new TAVI valve. And you can see the LV post and the LA thromb was still there, but she recovered quite well. And the gradient before was 50 to 60, the gradient afterwards was less than 5. Well, this was not the end of the story because she developed right femoral thrombosis. But after prolonged balloon inflation, we managed to restore the flow down to the femoral artery. She was discharged day 6 in class 2, and she gave me a phone 3 weeks later to ask me if she can invite her friends for a party at home. She survived for some years uneventfully. So the message is that in TAVI, you may have one of the usual complications, but sometimes you may have unexpected complications, and always keep calm and walk on. Thank you very much.
Wonderful case. Do we have any comments from the panel, please?
Yes, actually quite a scary case, a nightmare probably in the cath lab. My question is, after restoring all the flow to the LAD, before attempting to continue with the valve implantation, did you consider placing a filter at this point?
We had enough. And we thought that all the thrombus went down to her coronaries.
Congratulations for the great save, Petros. I have also a short comment. And since you did the transesophageal, and the save was very nice because you didn't use a stent. This is very, very fantastic. And I don't know, maybe it was from the thrombus that it was in the LV also and migrated also to the valve. And did you consider to put the patient in some more intensive antithrombotic treatment and come back for the procedure?
No, the patient was pretty unwell, actually. And one of the reasons that she was intubated was because we want to control her hemodynamics better. She was not weight. And actually, the transesophageal showed all this thrombus. We were not aware of the thrombus. And I presume that there was thrombus on her valve, on the peripheral valve as well. And this is why all the picture came after we tried to cross with a straight wire. Presumably some thrombus, some clot went to the left coronary.
Petros, this is Kostas. Hi.
Hi, Kostas. Hi, thank you for the invitation.
Petros, you keep surprising us every time with awesome results, great saves, unexpected things happening. And I'll say again, οι ασθενείς έχουν Άγιο στον Άγιο Λουκά.
This is why it is called Agios.
But not only Άγιο στον Άγιο Λουκά, αλλά έχουν και skillful cardiologists and teams ready to face any complications successfully. So congratulations again. Just a short question, because I wasn't there from the beginning of the presentation. Did you have any indication from the CT scan, the screening CT scan, that there could be any clots on the leaflets, any thrombosis? No, it was thin leaflets?
Yeah, that's right. And also the transesophageal, the initial TOE picture that we performed didn't show any thrombus. So clot in the LA appendage, but no thrombus. But possibly there was thrombus, small thrombi on the leaflets. But nothing obvious.
Right. We had a couple of cases that we had ham on the leaflets, on the screening CT scan in surgical valves. And we defer the procedure for a few weeks, giving syndrome, anticoagulation. Even if that was a false image of clot, it brings peace in mind that you've given anticoagulation. So if there is any fresh thrombus, it goes away. If it's an old thrombus that is like a fibrous now, you have no effect. But if you see something pronounced and marked, then you should think about deferring the procedure for like 4 to 6 weeks. And thank you again. Great case.
Thanks.
So congratulations, Petros. I'm Yorgos Georgiou from Nicosia.
Yeah, so Yorgo.
So just to highlight that crossing peripheral valve needs special attention because sometimes you can cross under the struts of the valve.
Sure.
And this can cause some damage to the whole system and makes the whole procedure catastrophic. It's the same just like accurate neo when you lose the weight, the wire, and you have to recross it, and sometimes needs special attention. Thank you for the nice demonstration of your skills.
Thank you. Thank you.
One more question in the back, and we should conclude. Dr. Pipilis.
Please. Did you have difficulty in maintaining ACT during the procedure? You had to use a large dose of heparin? Or
yes, we did. We had an ACT of more than 300 continuously.
Okay. So, our next presenter is Dr. Asnauridis from Hippocrates